And today we will be talking on role of radiotherapy in breast cancer. This is the second episode. So we have a good crowd today. We have our local faculty is Dr. Tawhida Yasmin, who is the senior specialist of radiation oncology in the Cancer Care Center of Evercare Hospital, Dhaka, who is a corporate hospital, and Tawhida is a very bright young radiation oncologist. And we have another very young radiation oncologist, Dr. Nusrat Haq, who is working in our National Institute of Cancer Research and Hospital. Both of them are very young, very promising. We invited them, even they are probably not taking independent decision, but they are part of the active decision making. So we went to listen to them. And as usual, we have three foreign experts. Dr. John Conybeare, who is the consultant oncologist in Birth NHS Trust UK, a very known face to us for last quite a few years. He has been supporting us. Dr. S.K. Farid Ahmed, who is orthoplastic breast surgeon in Beacom Hospital, and he is the head of breast unit in BRB Hospital in Dhaka also. A doctor born in Bangladesh, working in UK, now sometimes also working in Bangladesh, dedicated breast surgeon. Finally, we have Dr. Sarthak Tandon, who is the attending consultant of radiation oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi. Sarthak, we met him earlier in a training program. I found him a very dedicated person on radiation oncology, especially taking special interest in breast. Thanks to all for joining with us. We have our patron and our inspiration of all this program is Professor M.A. Hai, who is the president of Oncology Club. As per custom, I would request our president to say a few words formally to start the program. Professor M.A. Hai, sir.
Thank you, Kamal. Bismillahirrahmanirrahim. Great occasion for us today. We are going to discuss about the role of radiotherapy in breast cancer. It is our second episode. We have amongst us three foreign faculties: Dr. Sarthak Tandon from India, Dr. John Conybeare, Dr. Sheikh Farid from UK. Our local faculty, Dr. Yasmin. There are two from local faculties. So without delay, I think we should start immediately. Come on, go on. We have a very short time.
Thank you, sir. So we will be talking for 60 minutes. There will be no formal discussion presentation, but we'll be doing some case-based discussion. And we will make an opinion poll, ask the local faculties. Then finally, we will go to the foreign overseas faculties for some consensus decision. And please participate in the poll because the best participant will be awarded by interesting gift. So we are starting with our first question. Tanya, please show the poll question. In a breast cancer patient of clinically T1 to T3, N0 or N plus, N0 status, who underwent mastectomy and X-ray lymph node dissection, please identify from the following criteria who is not a candidate for post-mastectomy radiotherapy plus minus RNI. Pathologically node 0, T less than equal to 5 centimeter, margin more than 1 millimeter. Pathologically N0, T more than 5 centimeter, 1 to 3 axillary node, more than 4 axillary node, margin positive, not feasible for reactivation. Hi, John. Welcome.
Good afternoon.
Good afternoon. So, for some reason, I cannot see the poll question. But, well, Shuman? I cannot see the screen of the poll question. If it is 1 minute, then you stop and tell me the result of the poll.
It's right now 1:30. So I think you can change the poll form right now.
Okay, so what is the result, Shumon?
Out of 17, 15 is in favor of A and 2 in favor of B.
Okay.
Nobody, C, D, no is there, and E, 1. So more majority are in favor of answer A.
Okay, so I go to very easy question. We start with very easy question. So start with Nusrat. Can you please open a screen? We don't see you. So Nusrat, being the junior, most probably, what will be your pick? Which group you think is not a candidate for PMRT plus minus radius RNI?
Assalamu alaikum. At first, I want to say Assalamu alaikum to Professor Ime Hai sir and respected teachers and my colleagues. And thank you very much for giving me chance to talk in such a prestigious platform. On this question, I will go for A, that is pathological T0.
Okay.
I will go,
You will go for A.
sir.
Great.
A, yes, sir.
So Tohida, you agree with her or you have any other thoughts? Tohida?
Assalamu alaikum and good afternoon. Yes, sir, I do agree with Nusrat that I want to go with A, that this criteria, having the criteria of PN0T less than 5 centimeter and resection margin more than 1 millimeter is not a candidate for post-mastectomy radiation.
Very good. Very good. So you are correct. I mean, this is the NCCN guideline. Now I'm coming to Sarthak, that in the NCCN, they are telling that if it is a negative axillary node and tumor is more than 5 centimeter, they are recommending chest wall radiotherapy and plus minus suprainfraclavicular region. So can you please give some light on this plus minus story?
So, yeah, so you're talking about the category where we do not have any nodes, but we do have the indication for radiating the chest wall.
Yeah.
Maybe perhaps because of the size of the tumor or because of any other reason. The main issue lies with the fact that if there are any high-risk factors associated with the primary tumor. So what we do here is that if we have, let's say, for example, if we have an ERPR negative tumor with TNBC or probably a high-grade tumor, LBSI positive, for those tumors, there is a very high risk of recurrence to the nodal regions. And we do tend to include the undissected areas of our regional lymph nodes, which is primarily the supraclav and the infraclav. We try and leave the dissected axilla alone, and we do not treat it because then it will be an over-treatment for the axilla, increasing the morbidity to the patients. So that's exactly how we do it. We consider plus minus RT to these regional nodes in high-risk conditions. Otherwise, we leave it.
So, I mean, in addition to size, when you have some high-risk features like grade high or TNBC or then, I mean, this type of situation, very early age, I mean, this type of factors, when you think there is a high-risk feature and then you add the suprainfraclavicular, why? I mean, let me ask you a subsequent question that you are thinking of suprainfraclavicular. You are not thinking about the level 1 and 2 because are you happy with level 1, 2 with your conventional?
With my conventional radiation, that's what exactly you're saying. So, so the question is, it's a very complex question, in fact. So the recent data which shows that, if the axilla is dissected and you have an equal evidence and sufficient evidence that the axillary dissection is sufficient, so you address the axilla surgically well, there is no need to treat your axilla again, at least the dissected part. And also because of the conventional portals, they give you about 80% of the dose to the level 1 and 2, the incidental dose. I wouldn't want to treat axilla. In any case, we are going towards de-escalation of the axillary treatment. I mean, it would be futile to treat. Yes, if in conditions where the axilla is completely untouched and the surgeons have not gone and dissected it, and probably if there is an incomplete axillary dissection, yes, I would like to go ahead and treat the axilla as well. But most of the cases, we do not have, those indications. Our surgeons do address our axilla adequately. And if not, even if we have gone for a sentinel lymph node biopsy, even then, if it's negative, I wouldn't want to treat axilla in those cases.
Thanks, Sarthak. We will be, don't worry. In the whole session, we'll be talking about so much axilla. These things will come again and again. So this was the appetizer. So thanks for your comment. So we understand that, this is the classical indication of post-mastectomy radiotherapy. Then we need to individualize when there is node negative situation, when we will add the supraclav. So that is a easy life. Now another easy question. Can you please put the poll question, Tanya? So when we will not use supraclavian RT in your practice, more than 4 node, 1 to 3 node, no axillary staging and no ALND in case of sentinel node positive, or all case of invasive breast cancer, irrespective of anything. It is an invasive breast cancer, treat with 3-field, lateral, medial, tangent, and supraclav. So what will be your pick? So let us see the poll. Shumon, please help me because there is some technical issue. I cannot see the poll question answers. And you say when to stop. Shumon.
So only 4 participants.
Please, we request everybody to join. This is fun. It is nothing. And you know, there are some questions that there are so many answers. You don't know which is right and which is wrong. And it is not the right and wrong. It is the opinion rather. So we want to know, understand how people are dividing themselves in the decision making.
So I think right now it is 1 minute, so we can stop the poll.
How many percentage?
So only 33% participants are give their answers.
Who is in favor of which?
Okay, it's a tie. So B, C, D, all of them are 31%. Means for if each segment 4 participants responded out of 30.
That is quite interesting that people are interested not to use axillary supraclavicular node because it was not supraclavicular. It was a tricky question. So Tohida, you are nodding your head. Which group you don't want to put supraclavicular node radiation?
Sir, actually, this is a very interesting question. If we go from question answer number A, obviously, if axillary lymph node having more than 4 in number, I would like to give supraclavicular lymph node radiation. There are ample evidences.
Which one not?
Well, it is a tie actually, but if I had to tick one, I would go for C. No axillary staging, not no axillary staging. If a patient is sentinel lymph node biopsy positive cases, in that case, I am assuming that the patient is having low axillary burden.
Fine. So, Nusrat, among these 4, let me help you. You are the junior most. One is correct answer. Which one you want to pick?
All invasive carcinoma breast cancer patient, number 4.
Okay, so why you disagree with Tohida? She was telling she will not give supraclav when there is a SNP positive.
Sir, I can't understand.
So number 3, why you didn't agree with Tohida? I accept your answer, but and that is the correct answer. But why you don't agree with Tohida? That if it is SNP positive and axillary node is not dissected, why you will not go for
Sir,
it?
if SLNB positive, then we should dissect the axilla, or either we have to give the supraclavicular.
So it was positive, but axillary node not dissected.
So yes, sir. So you go for
Okay.
the supraclavicular
Great.
node.
So why I brought this question interestingly, you see, I used to read this book in 2010 when I started my training. Then I was very fan of this evidence-based handbook of evidence-based radiation oncology book. And the new edition came on 2018. So the 2010, they used to say that if it is axillary node 1 to 3, then you need to look for some risk factors to add the nodal areas and blah, blah. I mean, it was a quite complicated thing. But in 2018, they have said, well, if you have something 1 to 3 involved node, straight away you need to give radiation. This is the total paradigm shift in change of treatment of nodal radiation, and also saying that if you have inadequate axillary dissection or inadequate information, when we don't have any information, we need to treat it positive, and definitely we cannot ignore the supraclav. We don't have any debate of supraclav. We can debate on IM node that we will be coming. So the easy question is over. Now, slightly, maybe another tricky question for poll. What dose fractions you can use for RNI? 40 gray 15 fraction, 42 gray 16 fraction, 50 gray 25 fractions, or other fraction? Which is your choose for RNI? Shuman.
Yes. Right now, only 20 seconds. So I think we can wait a bit.
Yeah, please. I don't know what happened. I joined from another device, so they said I cannot see from this. So Shartak, in the meantime, let me ask you that when we are treating supra-infraclavicular nodes, but we are putting our upper level up to cricoid cartilage, covering level 4. We are talking about supra-infra, but we are taking level 4 of neck. I mean, what is the reason behind?
I mean, so again, this is quite a bit of controversial, and this depends upon, I think, the differential practices of various regions. I mean, RTOG and RADCOM, they want to treat it a little higher, and the Eastro people, they don't treat it as high as cricoid cartilage. But as far as we have seen in our practice, the practice of failures, I mean, we know that supraclavicular region is as such not a nodal dissection designated area. It's an overlap between level 4 and 5. If we talk about, I mean, if we take it as an interpretation from the head and neck nodal region. So the failure pattern, we've seen that in anything which is below cricoid, and in very rare cases to the retroclavicular areas, the failure rate is quite high, and therefore we should treat it in the level 4 region, which falls in the level 4 region of the head and neck, but acts as a regional nodal region for the breast cancer. I mean, that's how it is supposed to be. I mean, it is technically comprised of 4B and 5C, and along with 5B and C. I mean, that's how we treat it. So it's not.
Shartak.
Yeah.
John, are you there? John?
I am here, yes. Yeah.
So John, this is an old question, always come to my mind. When we discussed, we said axilla level 1, 2, 3, supra-infraclavicular. But when we treat this neck node also.
Yeah.
I mean, why we don't say it or why we treat it? I mean, what is the harm of talking about it? Well, we treat supra-infraclavicular and also level 4, or why we treat it? I mean, what is the harm? Why we are shy to talk about it, and why we are so courageous to take it?
Yeah, I have to say, I don't know. I think there's, you know, what I've learned over the last 12 months is what you define as your regional lymph node volume does depend on which atlas you pick up, and the technique by which your radiotherapy team will be planning your volumes for treatment. So if your planning team, are you going to use a SCF field, you know, then your exit dose will extend along, you know, the clavicle. Whereas if you're using IMRT, then your dose won't extend posterior along the clavicle unless you include it in your volume. So I find it really interesting, you know, that some people, I worry, don't pick that up. And when they're contouring what they want to treat, you have to remember what you've treated in the past to be relevant, if that makes sense. So, you know, moving to a volume-based system now, you have to think about where your dose was going in the past when you were doing 3D sort of conformal field-based treatment. Otherwise, over time, our outcomes will dip, you know. I do worry about that. And when it comes to voluming, I do think I end up treating more now than I did 2 years ago when I'm contouring patients, you know. I do see, when you add a PTV, you know, I see patients now who get a bit more esophagitis in the upper part of their SCF because my PTV just clips across their esophagus, whereas in the old days when it was a field, you know, and it was directed, you know, the field edge lay along the border of your trachea, you just didn't clip the esophagus. So it's, you know, it's interesting.
So I understand that with the era of this volume drawing from the conventional bony landmark, we are learning that things maybe we had done, maybe sometimes overkill, sometimes we miss something, sometimes we have done overkill. So all this volume is teaching us that how we need to move from here to there and some techniques. So this question seems to be a very easy one. My question to Tohida, are you agreed that we can use hypofractionated radiotherapy in RNI? That was the question behind the last.
So I
question.
do.
No, not to John. You okay? I'm asking them. I know you
Okay.
do. You are even in fast forward era, no, John? So Tohida, are you?
Yes, Kamal sir, yeah, I do agree that we can use hypofractionation in regional nodal radiation as well.
So are you not scared about the toxicity of dose
No,
when you are treating supraclap?
Actually, in our institute, there are many patients receiving, from my practical experience, I can say that comparing 50 gray in 25 fraction versus 40 gray in 15 fraction, 40 gray in 15 fraction patient do better in terms of. Hello?
So Sarthak, what is your practice? Are you doing hypofractionated RNI?
Yeah, we are, as a standard of practice, we are taking hypofractionated RNI. That's not an issue. I mean, we were initially scared of it, and I mean, where we had a heavy nodal burden in axilla or probably supraclav, we used to take a conventional fractionation. But over the period of time, we are very comfortable in treating with RNI, with hypofractionated RNI. And since we have got a lot of data also regarding that, there isn't any chances. I mean, serious chances of brachial plexopathy or, for that matter, skin reactions. I mean, there is no doubt. We're very comfortable in doing that.
So John, hypofractionated in fast forward RNI.
Yeah, so no, so we haven't adopted fast forward into RNI yet. So we revert back to our standard, which would be 40.05 and 15 for RNI. We're still awaiting the nodal outcomes for that. I have to say that, brachial plexus, is a factor, I think. Let's wait to see what comes out of fast forward and brachial plexus.
So fast forward, when there is RNI. Yeah, sorry, Sarthak.
Yeah, I think we have to maintain the EQD2. I mean, one of the trials that they came up with the data that EQD2 is something we need to maintain for brachial plexus somewhere around 55 and less. If we are maintaining that, I mean, we can easily go ahead and do an hypofractionation. I'm sure about fast forward, we need to see the data, but for the rest of the fractionation schedule, I think it's okay. And even with the inadvertent doses in start A and start B, there were certain nodal areas that were treated with those hypofractionated doses. And I think we're in safe zones for those fractionation schedules. But yes, for fast forward, you need to see it.
Yeah.
So I agree that when we are dealing with hypofractionation, what Sarthak was telling and John is telling, that we should be very cautious because the OAR dose is changing, because we need to convert the OAR dose to 2 gray equivalent, because whatever OAR in our mind is always 2 gray based. But we are treating sometimes near to 3 grays, sometimes in fast forward we are 5 gray per fraction. So it's a total different story. And we have some area like brachial plexus, brachial plexopathy doesn't happen immediately, but end of the day, patient may survive, but with the brachial plexopathy, that is not our target. So even people like UK people who are very famous for their hypofractionation, they started these things. Still, they are waiting for data to mature for fast forward. So they are coming back to 40 gray, 15 fraction when they are going for RNI. But as Sarthak said, initially we were a bit cautious about hypofractionated RNI, but now we are confidently treating RNI with 40 or 42 gray, either UK or Canadian protocol, whatever it is, 15 or 16 fraction. And in our center also, we are treating this. And I think this is not an area of discomfort anymore, which was initially for everybody. That it may be, I remember our American colleagues were very conservative about hypofractionated RNI. They were in favor of 50 gray because of this supraclap story. But slowly things are changing. So the message is that in the era of this hypofractionation, we can safely treat not only breast, whole breast mastectomy, and also RNI with 40 or 42 gray, 15 or 16 fraction. So the next question is, whole question, what is the indication of IM node? Any node positive, only IM node positive, or the location is central or medial, or when the patient is having a heavy nodal burden. Who is a candidate of IM node in 2021? iron node radiation. Come on.
Give 27 seconds.
So anybody having their question, they can put their question in the chat box, and the later part we'll try to discuss it. Over, I think we don't need to give that much time. It is a very easy question. Today, the questions are very easy.
So I think it's about 1 minute, so we can stop the poll. So 46% participated. So out of 15% in favor of A, 40% in favor of B, and 85% favor in C, and 25% in favor of D.
So good, everybody is in favor of all the groups. So, I mean, if you look, that the classical indication till now is when this iron node is positive, but in other situation, all the situation, the clinician can take a decision of iron node treating. So, well, what is the practice of your center, Tohida, when you treat iron node?
In our center, we treat internal memory node only if internal memory node is positive or the tumor is located medially or centrally.
Great. So, Nusrat?
Sir, in also our institute, we treat iron node in case of iron node positive or central or medial location tumor.
So if a heavy burden tumor, say 10 out of 10 or 8 out of 10 is positive, but iron node is not positive, will you treat iron node?
Yes.
Yes,
Yes,
sir.
you will treat. Sarthak, please help them. What is your culture of treating iron node?
So our consensus is, again, any answer here goes well with certain amount of data backing it, I'm sure. But what we do at our institute is that if it's a central and medial location, definitely. If it's an IM node positive, definitely. But we also look at the, the characteristic of a primary tumor. If it's high risk primary tumor, we have certain elements with high grade, LVI positive. We would like to follow the RNI, the comprehensive RNI way. And I'll be more liberal in my indication for treating the internal mammary node if it's a right-sided tumor. Obviously, I'll be a little cautious if it's a left-sided. I'll keep my indications a little constrained. And if it's a heavy nodal burden, yes, if in its case of a right-side tumor, and if it's a left-side tumor, I try and avoid it if I do not have a higher-end indication, sorry, a higher-end technique to treat the patient. I mean, I'll be a little worried about my the offset of advantage that I will give by treating IM in vis-a-vis the doses that I give to heart. I'll be worried about that.
So what do you mean by high-end treatment, Sarthak?
So what we do at our institute is for left-sided tumors, we practice a deep inspiratory breath hold, and we follow a conformal technique. We try and follow a conformal technique, but then again, a lot of issues are, logistic issues are a matter of debate here in our, we are in a logistic restrained country. So that's an issue, but then let that aside. If it's a we follow a deep inspiratory breath hold technique and we follow an FIF. If that's available for me, I'll be happy to cover that area.
Okay, Sarthak, you don't have a DIBH. Will you not treat IM node?
For left-sided tumors,
Yep.
That's what I'm saying. For the left-sided tumors, my indications for treating an IM node will be a little more stringent in comparison to the right side. So if it's just, it's a frank indication of central medial tumor, probably a IM node positive, and if it's a heavy tumor or a heavy nodal burden, then yes. But if it's just because of the high risk factor in the primary area, then probably I'll let go of that area to treat.
So very small question. Which area you cover? 1 to 3, 2 to 4, 1 to 4?
I do not go beyond, we do not go cranially beyond the first intercostal space, and then caudally we treat it to the cranial end of the fourth rib.
Oh.
That's
So
it. We do not go beyond
1 to 4.
Yeah.
Because in different studies they have taken different.
Correct. So cranially we do not. So most of these studies, they differ in terms of cranial borders, I think. So we do not extend our cranial borders beyond the first rib, and caudally we take it up the cranial edge. I mean, I don't know about the rest.
John, I am not.
So I use it in heavy nodal burden. I use it in patients with, as it mentions there, clinically radiologically, pathologically positive IM node involvement. Not always will I do it for central or medial tumours. I must say I'm more selective in terms of the patients I use IM node radiotherapy. I remain concerned about the long-term consequences in terms of cardiac issues, you know. So the risk-benefit ratio really has to be, I really have to feel that there's a risk of relapse for that patient to do it.
So, John,
Yes.
the tumor, you have, IM node is not positive. Let's forget about positive, but other factors are there. The physicist is struggling for the anatomy, cannot achieve your given OAR dose of the heart. So a trade-off, what you are going to do? Sacrifice some of the IM, or you will take some higher dose of the heart?
No, I'd sacrifice the IM. So I would say compromise target coverage and keep the heart within tolerance.
Okay, so I am a rich guy. I have BMAT, I have IMRT, I have SBRT, whatever you ask for. Even gamma knife, not going to treat a gamma knife with breast, but well.
Protons, yeah.
Yeah, proton, well,
I get patients come for some protons, yeah.
Yeah, now people are asking. That day one guy was asking breast cancer, can we treat with proton? I had to sweat for half an hour to explain why don't need a proton. Okay, so I mean, I am not targeted treatment on left side, not for right side. What is your favorite technique that you want to choose?
So we do it all with IMRT.
Sorry?
We do it with, so we'll attempt to do it with wide field, yeah. But I would say often it comes back to, you know, you can't get your heart into tolerance. So we'll end up doing VMAT. So VMAT or IMRT to get coverage. So
Shartak, John is in favor of VMAT, but I struggle with VMAT with lung dose, low volume lung. So at one day I was telling my physicist, forget VMAT when I'm treating a breast, don't go beyond IMRT. Do you agree with me or you want to be with John?
No. So I'll take a middle road and I say that there are certain cases where ARC is required. But yes, I need to explain to the patient that, you know, you'll have so the low dose to the lung area is going to increase, and but I'm going to save your heart. I'm going to compromise. I am going to probably save high dose area to the critical structures of the heart, if that's exactly I want to put it. And though in the offset, I'll increase my lung doses, and especially if the patient is at risk of any lung pathology, probably if she's a chronic smoker or something of that sort, then probably I will not go for an ARC. And we generally don't go for an ARC at our institute. We go for an FIF, and we generally get good plans with it. And if we are not getting a good plan with an FIF, I think we go ahead and do an ARC in only those cases, yes.
So John, you agree? I mean, you are more interested to the saving the lung and taking some low dose saving the heart and taking some low dose to the lung?
Yeah. So again, it comes back to risk benefit. If I've pressed the button where I think their risk of relapse is such that I'm willing to do the IMC nodes, you know, and I'm happy to do a VMAT, you know, and I still want to get full coverage, then you know, for my ability to sleep at night, I personally feel that low dose through the lungs, you know, hopefully they'll live long enough to never see a problem through their lungs, but it's all about curing their cancer. And that's what, you know, if they're not cured, it makes no difference, if that makes sense.
I'm happy. I'm sure Shuman is very happy because Shuman is a fan of VMAT and I'm always fighting with him for IMRT in my center. Shuman has some good support.
In all due regards, I think for the VMAT, I think there are a lot of evidences now, at least for the dosimetric evidences which are coming up for ARC. So I mean, I think we'll have to go for all ARC therapy for most of our patients. I mean,
yeah,
I think that.
I mean, you know, maybe for the gray hair, we are going a bit slowly, but not just taking a long jump. Okay, so we are going to the next question. Who is not a candidate for axilla and IM, the new adjuvant. Very locally advanced patient, residual node positive after NACT, sentinel node positive after NACT, PN0 after axillary node dissection. Among all, who is not a candidate for all the three areas, that is classical RNI, that is supraclav and axilla and IM. Shuman, help me. Did for it join? Shuman?
I was struggling with this link issues. Right now, I have sent the ID.
Okay, okay.
Probably he will get.
So you help me to finish the whole question.
I think right now it is 45 seconds. Most majority are in favor of this answer D.
D.
D, yes.
Okay.
And after that, 13% in favor of A, 12% in C, and 5 or 6% in D.
Nusrat, which one or which many is your pick? Maybe more than one is also correct. We don't know.
Sir, I will first go for pathological N0 after axillary node dissection.
You will go first for that one. Which second one will you choose? Will you take any second one or you will stop here?
No, I will stop here, sir.
Okay, so Tawhida, you are with.
Yeah, I agree with Dr. Nusrat. I want to pick
Okay, great.
the patient who are having complete pathological response.
So that is an area of interesting area that after neoadjuvant chemotherapy, what we do. So these are the people that have T4 or N2 and 3 disease and T3B and T3C. They are having a more beneficial, but we are waiting for this NACBP B51 trial to really give us the information to select the patient. So Sarthak, after NACT, what is your practice in your center?
So yes, again, for those patients, because the chances of recurrence and relapse is less than 10%, we don't. For this particular subset, I am a little, let's talk about where we definitely give the regional radiation as well as the local radiation. For cases where probably, have the nodal, it was a T3 and node positive disease initially upfront before NACT, or if it was an N2, N3 disease initially, or if it was a T4 disease, definitely for those cases, I would like to treat it irrespective of the response. And for those patients, it's only in the subset where it is, the subset which is being studied in B51, the T3 or node positive initially, but now have responded in our in PCR. Then it's going to be a discussion on a case-to-case basis. It's going to be, a tussle between the surgeons and as well as the radiation oncologist. We'll have to sit and decide as to why, because the local regional recurrence rate is probably less than 10% in those cases. So it's a matter of controversy, and I'll have to wait for the B51 to come up with the results for that. Rest, for all patients who are heavy disease, pre-NACT, T4, N2s, N3s, I will treat it post-NACT.
Sarthak, very interesting. You see the bad biologists respond good. Bad boys do good in the result. So the TNBC or HER2 positive, we are getting 50-60% PCR. Right. So TNB, let's start with a dual block of TNBC. PCR.
So again, if it's a TNBC and it's a PCR, we do not have enough evidence to suggest that just based on the biology of the disease, I would like to treat it. I'll also have to look at the T stagings and the node stagings. Yes, my biological disease status, they tend and reform my strategies of treatment, but they do not form a basis of my treatment. I do not have any evidences, or at least a prospective evidence for basing my decision on the basis of these biological markers. So I'll hold if it's a complete response, and if it was an early disease, TNBC, I will hold my radiation to those portals.
What about dual blockade? You people are very, neoadjuvant dual blockade. It is NHS funded and 60% PCR. So yeah, will you go for RNI after PCR?
It will depend on there's some select patients, so it's not routinely, yes, we will for everyone. I'd say it depends on what their presenting tumor was. For instance, I kind of sometimes feel a bit nervous, say they've had, you know, the rare patient gets a PET scan, and if they had no positive disease on PET in the IMC, yeah, and they haven't been removed at the time of surgery because they've had, you know, axillary clearance for, then yeah, I'd have a discussion with the patient.
So the answer is that for what Sarthak and John is telling, that when after NACT, if it is a PCR, then this is something, we don't have a black and white rule. We need to assess every patient by patient, assess every risk factor, and also discuss with the patient the risk-benefit analyze ratio. Then we need to take a decision. It is not 2+2 story when there is a NACT, and especially when it's a PCR. Then the life is sometimes is really difficult to be or not to be, like a story. Shall we give or shall we not give? Okay. So RNI, where we are. So these are the three interesting trials. A quick review: URTC, MCIC, and DBCG IM-node. And this URTC was, they have taken that I was telling, they have taken the IM-node for 1 to 3. And after treating, they have shown that there is benefit of DFS, but no OS. And only the node positive group were mainly benefited. And again, on this NEGM publication, where they have treated IM-node also, again up to level 3, intercostal space 3. And they have also shown that there is no OS benefit. But this study, DBCG IMN study, they have shown that taking IM-node is giving some OS benefit. But again, if you look at the subset analysis, you will see that the hazard ratio is interesting when there is more than 4 nodes. So this is the area where we can still, and if you look at this analysis, there's the presentation of San Antonio, 41st annual San Antonio Breast Consortium, 6 studies they have taken, and 10,000 patients. They said that RNI reduced the risk of breast cancer recurrence, reduced breast cancer mortality, reduced overall mortality. And they found that the significance was there, but still, as we discussed, this is an area of controversy. So if we look at, we have conflicting data. There are some data in favor of RNI is beneficial. Some data is said that RNI is not helpful. And some data is there still that RNI is harmful. So we are still waiting to have more data to take a clean-cut decision on RNI. So the question is axillary coverage by tangent field. Tohida, when we are treating, we are conventional axillary radiotherapy. Are you happy with your axillary coverage? Conventional lateral medial tangent.
Well, it mostly it covers the tangential field, but in some patients when the chest contour do not permit, chest contour is something that the central lung distance become more with the tangential field, then the covering the axillary field becomes a bit challenging.
So are you happy with if it's a nice, I mean, as per requirements body contour with a tangent, you are happy with your axillary coverage? 1,
Yes.
2, 3.
Yes.
Nusrat?
Sir, in tangential field, we can cover level 1 part of level 2, but not level 3.
So you are telling that in conventional, you are not happy with total coverage. You are getting a coverage of level 1 and level
part of level 2.
2.
Part of level 2. Yes, sir.
So, well, that is a discussion. And so, do you practice high tangent, Mr.?
In some cases, we practice high tangent in our institute.
Why? When you use high tangent? What is the definition of high tangent to you? Because in the globally, many people define high tangent in different way. So that is another discussion I'm going to do with John and Sarthak. So what is your definition of high tangent? When you say it is a high tangent?
Sir, it is radiologically when we see the head of humerus at the level of head of humerus to below, just below the head of humerus, upper level of our tangent
So
field.
your high
is-
tangent definition is going to up to the lower border of the head of the humerus. So what do you want to achieve with
Yes, sir.
high tangent? What do you want to
Sir,
achieve with this?
So conventional tangent field doesn't cover the part of level 2. So high tangent mostly covered the part of level full level 2.
So, okay, let me say that we have treated a patient with a high tangent, but still you have covered level 2, but we want to treat axilla. So is it enough to treat with high tangent, or you want to add?
No, sir, we have to add supraclav.
Okay, so for you, to treat a total complete axilla, you need to have a high tangent and a supraclav.
Yes,
So
sir.
I know there is no right and wrong answer. Sarthak, will you accept her answer?
I mean, our conventional strategy used to say that if we take a high tangential, then we are able to cover axillary. But we have a lot of studies which say that no, we cannot cover axilla properly, even with the high tangentials. And what we're going to miss, what we're probably going to achieve in axilla, we're going to lose in supraclav, because you know what, you are taking that area which needs to be treated with direct anterior from supraclav, because if you're going to increase your medial border, I mean, the only condition that we take high tangential is where we do not need to treat supraclav, and we have a liberty of probably underdosing supraclav in those conditions. I mean, that is otherwise high tangential should not be a measure of treating your axilla coverage, increasing your coverage. I mean, they say that level 1 and 2, it increases to 80%, but level 3 is still underdosed.
So John,
Yes.
high tangent, supraclav. I want to
Yeah.
treat all the 3 level 1, 2, 3 comfortably. So
Yeah.
conventional tangent with the supraclav or high tangent with the supraclav. Which one will you choose?
So the reality is, if we're going to be doing the axilla, I will have contoured it. So essentially, there'll be a volume on the plan. There'll be a volume on the CT data set that the planning team will look at. And so if they can't cover what I've contoured, they'll switch to IMRT. So it comes down to making sure that they can get coverage of what I've drawn around. They wouldn't do a high tang and an SCF field if it wasn't covering what I've drawn. Does that make sense?
Yeah, it's a very intelligent answer, John. I draw a volume, let the physicist take care of the thing. But say I don't have the liberty. So this is sometimes confusing. This type of data, the papers coming out that the adequate coverage is not done by high tangent, normal tangent, and without high tangent, the coverage is really poor. And then the question comes that, to contour it and cover it, or in a bony landmark era, to go for high tangent and take a supraclav. Yes, John, you wanted to say something?
You know, this is, to me, personally, on a personal level, this comes back to like a fundamental thing that I do. So whether I'm doing an 8-gray single for a metastasis or a 20-5 or a radical plan, you know, I will draw around what I want to treat, and then whether they put a direct field on and it's prescribed, so that I know when I look at the plan that what I want to get treated is getting treated. Yeah. So that, to me, there's no confusion then between you and your planning team, yeah, in regards to what you want and what they're going to do, if that makes sense. It takes more time because then you have to draw around something, yeah. But
say, John, I don't have a CT. John, I'm a poor guy. I'm in an area where I don't have a CT. Then
okay. Well, if you don't have a CT, then you've got to rely on something, and then, you know, it'll come back to Saunders' principles of radiotherapy planning based on bony landmarks, won't it? You know, so that's then if you don't have a CT and you're going to be doing it on orthogonal films, then it's going to be bony landmarks all the way. And we know from bony landmarks that you do miss things, you know, all humans aren't the same.
Okay, John. Sarthak, so in a center, don't have a city. I want to cover all the 3 stations. Will you be for, again, the conventional with supraclap or high tangent with supraclap?
So if I need to cover all my 3 stations, I would still like to go the conventional way because I'm more confident in my practice covering with the conventional, the standard fields along with supraclap rather than going for high tangential and then using compromised SCF. I'll be more comfortable in using my standard tangential fields. Because I mean, the humoral dose is going to be an issue, and the normal toxicity is going to increase. The normal tissue toxicity is going to increase if I use the high tangential. And if I'm not sure about the coverage, there's no point of using it. So I would still go the conventional way of treating our MLTs along with SCF rather than going for a high.
So you are in favor that if we are not taking supraclap in some situation, we want to cover the axilla, then we can only use high tangent. If
I would
have a
prefer
supraclap, I will take the conventional.
Yes. So if I want to treat supraclap, I wouldn't want to treat high tangential.
So John was in favor of drawing, contouring. Yeah, John.
Yeah, definitely. I mean, if we have a CT and if we have, if we have the structures and we have everything on a side, definitely I would like to go the volume-based planning and draw my contours and be very sure as to what I'm treating and what am I getting at. But if I don't, I mean, that's the best that I can do.
Here is the problem. Sarthak, look at the Astro and RTOG. 2 is talking 2 different. What to choose, what not to choose.
I mean, their strategies for drawing these contours and the guidelines are completely different. One is probably the anatomical landmark based, and the other is vessel based. So what we have found is that we use both, and then it's a matter of convenience, I think. So for those patients who have had intact breasts and unoperated, we are trying to conserve, do a BCT and breast conservation therapy. We follow an ESTO guideline, and it's more appropriate and more accurate. And if not, and if it's a PMRT and if it's probably a locally advanced where we have operated a lot, then we follow an RTOG. Though there has been a lot of evidences for that there is no difference in either of the 2 guidelines in terms of coverage. I mean,
okay,
so
John.
we follow both.
So John, so this already we discussed. There is a scenario that sentinel node biopsy could not be performed and only a few lymph nodes were removed by axillary lymph node dissection and were negative. So here, will you treat the nodes? What factor will influence your decision? LVSI, triple negative, grade 3, etc. Because we could not do SNB and say there is a classical term, axillary sampling, 3 or 4 nodes were taken out. The patient is in front of you. Will you do RNI of this patient? Common scenario. Believe me, we get this type of patient. I'm sure Sarthak also get this type of patient.
Yeah. So one of the questions, of course, is will they clinically know positive preoperatively? So they had any imaging up front, ultrasounds, clinical examination, something that makes you suspicious that they had nodal involvement yet, even if the sample was negative. So that would definitely sway me towards RNI. And then it comes back to what you showed on probably your very first slide, for SCF, there was one statement in the NCCN guidance that has level 1 evidence. All the rest don't have that written in brackets after them, which really does these days allow you to do SCF in any way that you feel it's necessary.
Sarthak, would you give plasmastectomy radiation to T2N1 triple negative breast BRCA positive patient who had complete response? This already discussed, but this is a bit difficult. We made it also BRCA is there. So we will treat.
Again, I mean, given I'm not talking on a trial basis, I'm talking about my clinical practice. Yes, I will not base my decision on BRCA mutations or BRCA positivity. I would still follow my the tumor characteristic, the classical DNM.
So yeah, I would say that the BRCA is a risk for the development of cancer, not the risk of relapse of their cancer. So I would take in, as you say, I take in the other factors involved in the patient's case.
So John, I understand that you are not taking BRCA as a thing, but here we have a situation. Would you recommend RNI to a triple negative breast cancer underwent lumpectomy, and external node dissection. Say 1 or 2 out of 15 node is positive. So will she be a candidate of RNI for you? So low nodal burden.
So again, it depends on grade 3, young, so in her 30s, then versus if she was in her 90s, there will be factors, comorbidity, I would probably err towards discussing it with her. Some patients, before you've opened your mouth, they say, I want everything done that will minimize risk of my cancer coming back, And so it also depends on the patient's feelings as well. If they have a very fixed view on what they want, I'm not saying I do it in your PN0, there was some patients who I would counsel them against it, but if there's a small risk and they're willing to accept the potential toxicity, lymphedema, but they want every potential percent reduction they can get, then yes. And I think these days, if you're voluming your nodal regions and you're delivering your radiotherapy using VMAT, IMRT, then I think, toxicity becomes less of an issue, it would feel. So, a lot of the data that we look at for toxicity is based on conventional radiotherapy delivery techniques. And we've seen in only a few studies that have been conducted looking at the benefits of intensity modulated radiotherapy in the management of cancer. There's a couple of studies that do show it reduces toxicity. Probably not enough studies given the free adoption of it into all tumor types, really. But
so what reminded me after listening to both of you that every patient, we need to think about all the pros and cons. It is not these are the situation, there's a gray zone. There is no straightway recommendation, but we need to think about. But again, as you said, if we look at the data of the survival of breast cancer when it was against of mastectomy, radio PMRT, but when they have taken out the death caused by cardiac cause, then we found that the cause was not for breast cancer. And then we learned two things. One, that we should save the heart, and another, breast cancer is not killing people like the heart was killing people. So now the era of IMRT and rapid VMAT is giving us some opportunity to save the heart, and then we can take a risk of treating this patient. So Sharthak, this is your question. What is the role of RNI in a postmenopausal female with clinically positive, hormone receptor positive breast cancer, underwent lumpectomy and ALND with low volume nodal disease, say 1 out of 12? Because in Z11 and MROs tell that CN0 patient and adequate external lymph node dissection is considered definitive treatment. But what about patients who have low volume biopsy proven CN1 disease? Do you treat with high tangent or addition of just supraclavicular field, or do you treat comprehensively to include supraclav and IM field? Does age play any role? It's a huge question. So it is a ERP positive, hormone positive, low burden. So how you will handle it?
So my issue would also be with the regards of the size of the primary tumor, and also what is the size of the metastatic tumor burden or the tumor, the metastatic, deposit in the node, because that's going to differentiate. Because, if you look at the AMAROS trial and as well as the Z11 trial, you see that the subset that they've taken, so the median tumor size was about 1.7 centimeters. And we know that, Dr. Kamal, in India and as well as, and I'm assuming in Bangladesh also, we do not see so early tumors in our T size. So if the tumor size is high, and if the metastatic the deposit in the lymph node is in the range of more than probably 2 mm, I wouldn't be very comfortable in letting go of my RNI. I would like to treat that patient up, because that is not an ideal candidate who fits the AMAROS picture. So I would like to know.
So this information we need to take all. Always we are. But today we have been discussing. We need to take all the information together only on 1 or 2 point, only note one note positive or triple negative or hormone receptor positive. This one information or 2 information is not enough to take a decision. We need to take a whole decision. So Dr. Farid, this already discussed, the technique for RNI, 2D, 3D IMRT already discussed. So I'm moving to our surgeon. Farid?
Assalamualaikum.
Walaikum salam. Sorry, there was some issue. You joined a bit late for the connectivity, wrong link.
Sincere
I have a
apologies.
question to you. Will you offer axial lymph node dissection for SNB negative if there was no history of NACT?
If sentinel node biopsy is negative, what's
Yes.
the point of offering X-ray?
Will you do X-ray dissection?
No.
No. So you will not do X-ray dissection because that is the recommendation, and it is a very meticulously mentioned that should not recommend X-ray node dissection for women with early stage breast cancer who don't have a nodal metastasis, and if SNB is negative, we should not go for it. So why? Because X-ray resection recurrence after SNB, if you look at this data, that is 48 series, 14,000 patients. After SNB, only 0.3% X-ray recurrence in 3 years median follow-up. And this RCT, 8 years follow-up, they have shown that only 1.2%. Another B32 RCT, 8 years follow-up, only 0.7% was the recurrence. So that's why we are in favor of Farid with you. But will you offer SNB to clinically N0 after NACT? Radiologically, clinically N0.
Thank you. We would offer axillary sentinel lymph node biopsy, and in UK, we would also offer her in my unit. We'll do OSNA, one-step nucleic acid amplification, and if it shows micrometastasis, or even if it shows ITCs, we would proceed with axillary clearance, level 2.
So what Farid said, that you look at the 5 series, everyone have around near 20 studies and 1,000 plus, except one, 1,200, 1,700, 2,400 and 1,400 patients. But the identification rate is 90 plus with SNB after neoadjuvant chemotherapy, and false negative rate is near about 10%. And outcome of SLNB after NACT and N0 is that if you look at these 3 data, 1 from Japan and 2 from here, the nodal recurrence is near about 1% maximum. So somebody may argue that after NACT, maybe we are keeping some chemo-resistant clone behind. So SNB may not be a good decision for them. These are the reference that SNB has proven to be worthy, and we don't need to dissect the axilla where there is no indication. So for it, I mean, if there is a residual after NACT, will you go for LN?
Obviously, we will for local clearance, and also this will guide us with further adjuvant treatment planning as far as like radiotherapy, how much radiation dose we are going to include. If it is for more positive nodes, obviously you think about radiating not only the breast or chest, also the SCF and internal mammary chains. So all these things, information should be guided based on the nodal positivity numbers. So we would, yes, answer is simply yes.
So why not we give radiation? Why to do the dissection? Amaro said it is equal early stage. I mean, we can take care of the.
The problem is if after neoadjuvant chemo, we don't know how many positive nodes are there. And post neoadjuvant chemo, there is downstaging of not only breast, also downstaging of axilla. And despite downstaging axilla, if you find a good tumor volume in the nodes, one may consider axillary nodal dissection. We would consider axillary nodal dissection.
So for it, thank you. I mean, yeah, I mean, this is okay. I mean, we can go for both the way. As a surgeon, you have your point, and as a radiation oncologist with MROs, but unless the alliance trial give us the result, we cannot give a definite answer for this. So I think now I can go to the chat box. Mastectomy without axillary dissection. How to manage? Sharthak,
Sorry.
mastectomy done, but no axillary dissection was done.
Mastectomy done, and there was no axillary dissection
No
done.
axillary dissection.
So I'll have to cover it. I mean, like, there is no doubt about it.
So
I'll have to cover the entire.
Are you scared that this dissection was not done? Are you happy?
I mean, yeah, but I'm assuming that because that the dissection was not done because of certain reasons, and if so patient comes to me and I mean, I'll have to treat, and obviously there are chances because you need to address the axilla first, either by sentinel lymph node or by axillary lymph node dissection, and then only take those patients up to axillary artery. So this patient is going to have a compromised treatment, but suboptimal treatment. But then yes, if you ask me, I'll have to definitely treat an RNI. Given the fact, I'll have to explain the patient that the chances of axillary recurrence are pretty high.
Yeah, so I mean, say for example, the situation there was a axillary dissection, no dissection. I mean, when there is no dissection, we treat it as a positive and we are treating. So dissection done, 8 node was positive or 4 node was positive, no dissection done, we are treating all the RNI, all the areas, axilla, supraclav, even iron. So what is the wrong? Because this dissection is not therapeutic. This was more informative prognostic. So why we are scared that dissection is not done, we are at a risk?
No, so the question is we need to, so there, in any case, if it's for, even for, you know, addressing axilla, be it for our, you know, tailoring our approaches or further adjuvant treatments, but we need to see what the axilla is. It's all about what is going on in axilla. So you'll, I mean, if it's a high risk primary tumor, or even if it's a general tumor and with no high risk features, and if we don't know what's going on in axilla, I mean, we shouldn't, and at least for the time being, not unless we have a trial coming up with sound. I mean, the sound trial comes up and says, you know, we have a high frequency ultrasound showing us that the axilla is completely clear, and the radiation oncologists they are okay to go for the radiation treatment, and still would be, you know, skeptical about letting go of all the any kind of axilla treatment or dissection.
So John, there is a question that, do you practice RNI even after level 2 axillary lymph node dissection? It's a question from a surgeon, because their surgeons are always very telling that, well, I have cleared up to level 2, I have cleared up to level, I have done level 3. You know, they are qualified enough to do the dissection, we are not. So if they have done a dissection up to level 2, I'm not sure, probably the answer a question is, we will never treat if the node is negative. But if the level 2 dissection is done and there is a positive, so will you practice RNI even after level 2 axillary lymph node dissection done and there is a node positive? But they have taken it out.
Yeah, I kind of rely on my surgeons. If they say they've done it, then I don't normally go back and add to it. One of the things I do wonder about is when they've done an axillary clearance, and in the histology report, they comment on extracapsular spread around the nodes. What do you do then? Do you think there's microscopic disease still in the axilla after extracapsular, you know? So that's one of the things I sometimes battle with mentally when it comes to RNI and histology reports. But to answer your question, if the surgeons I work with, you know, Zach, who's not here this morning, if Zach tells me he's been in and he's cleared it, yeah, then I don't normally go back to add RNI to where he's operated.
So if the axillary level 2 dissection is done, 2 scenarios, one is no node found, another is 5 out of 15 nodes positive.
Yeah.
He is the trustworthy, Farid is there, he is the most trustworthy surgeon. So will you change your pattern of radiotherapy, John?
If they think that there's potentially still more nodes there, then I will go and do radiotherapy. So if they say to me, John, you know, I didn't manage to clear everything, then I will go back and add it into my volume.
So you will spare axilla, but you will treat the supraclav.
Yeah.
So the area, Sharthak, is that when we have a definite information about axillary dissection, we can trust our surgeon colleagues that they have done the surgery dissection then we can spare the axilla, but we need to take care of the other areas because that has not been taken care.
Yeah.
Am I
So the
correct,
dictum
Shah?
is, yeah, I think what we follow at our institute also is that if our surgeons are comfortable and they are very confident, the dictum is undissected axilla. So whatever area they've left behind, we treat that. We do not go and treat the areas which have been dissected.
So Sarthak, if somebody is not putting a clip, how I know how much they have dissected?
So so what we have to go by their level of dissection. So if they've only dissected ALND, they've dissected 1 and 2 levels, I treat 3 and infraclav and then supraclav. So that's how I did. And there is one other practice that's a very interesting practice that the Tata people, the Tata Memorial people, they follow, and they do something of a low anterior neck. So this is something between sentinel lymph node dissection, sentinel lymph node biopsy, and an axillary lymph node dissection. So they go ahead and do a low anterior dissection, which is just the dissecting the level 1 area as a counterfeit for SLMD. So, I mean, I don't know if that's a standard practice, but it's an interesting practice to see that, you know, you can just get the idea of what is going on in axilla and then treat the rest of the axilla by RT.
So that we need to wait for their mature data to
Correct.
come with their
Correct.
practice.
Correct.
Because
I agree.
Tata is doing
100%.
so many great things. Sometimes the result, you know, it coming out positive or negative, we need to wait for that.
Correct.
Till now, the standard
Agreed.
practice that we understand from the discussion is that once the axillary dissection is done and we are happy with the dissection, we can avoid the axilla, but we cannot avoid the remaining part of the RNI. Good dissection
Correct.
doesn't mean that we
We
can
don't.
spare the supraclav, we can spare the, if required, even the IM node also. But
True.
only thing that we can trust our colleague and depend on that is the axillary dissection. So dissected axilla, we can avoid double modality and to avoid the morbidity. So last question to both of you. In IM node treatment, young, in your practice, what is the acceptable lung dose? For Sarthak and John, separate answer.
So we, we do not change our constraints for IM and if we give an IM and RT, we do not change our constraints. I mean, we still have a stringent V20 and V5 levels. I mean, I don't, and if I'm using an ARC therapy, what I add on and I would like to, what I'll ask my physicist is that they also maintain the mean dose to the lung. I keep it as low as, I ask them to keep it as low as 7 gray, but they manage to do it somehow around 12 gray.
John?
We have IPSI lung, 17 gray, less than 35%.
Because why Shumon asked, I know, because sometimes I fight with our physicist and they try to bring some excuse, sir, I am not, you need to allow some more dose, something like that. So last question to Farid. Farid, do you change your pattern of dissection of axilla based on the tumor biology, or you go up to this, or you want to take more nodes when it's a heavy burden or triple negative or a very young lady, bad biology, or it's a very decent, gentle type of tumor who should do the less dissection. So does it guide your dissection? Say, we have been talking about radiation, that does this guide our radiation? So does it guide your dissection?
Thank you. To some extent, a little bit individualized, but generally speaking, common practices, we do level 2 axillary clearance for most of the breast node positive patients. However, while you are doing surgery and you see there are lots of positive suspicious nodes going beyond level 2 higher up, then obviously we would go for level 3, which is not routinely practiced in the UK. So most of the time it's level 2, and on some selective cases, depending on the nodal burden, we would proceed to level 3 as well. Thank you.
Thank you. So I think I have taken more than 15 minutes time than scheduled. So the people are dropping from 52, it came down to 36. It's an indication that we stop here. It was a great discussion. And next week, we are going to have the session on metastatic breast cancer on TNBC. Dr. Mustafa Aziz Shumon will be the moderator. And Dr. Zakirullah and John will be our overseas faculty. And we are waiting for another medical oncologist to join. And thanks to our academic partner, Roche, for supporting us. So I think it was a great discussion. I learned many things. Believe me, from today, I will change some of my own practice after the discussion. Small, but very important. modification that I will do, because every day we discuss, every day we learn, every day we enrich ourselves. Thanks to our junior faculties, Tawhida and Nusrat. I salute your courage to be on the platform where John and Sharthak was there. And this was really great. When I was at that age, I was not courageous enough. Hats off to you that you could dare to talk in front of this great oncologist and also Farid. And thanks for it. I can see that you are still in the car from this journey. You are joining us for supporting. And Sharthak, this is the first session that you joined. Hopefully you liked it. And we will be expecting you in future. This is how we are trying to enrich ourselves. I mean, every single of us are trying to learn and educate ourselves. And John, the old friend, now we don't treat you as a overseas guy. We are applying to the government to give you citizenship. Hopefully it will be granted very soon so that we can treat you as a local. So we are so, comfortable with you. Thanks to you, John. So Tanya, will you please show the poll answer, winner of last week? It's very interesting to see the poll winner of last week. I have seen the result and it was really amazing. So Professor Colonel Mufaddal Hussain, Brigadier General Mohammad Qudrat Elahi, and Dr. Tanya Afroza. Probably the second senior most person of last week's attendant was Professor Mufaddal Hussain, and Brigadier Qudrat Elahi is also a senior person. Why it is interesting that this shows that these senior people are joining with everybody to encourage everybody. At this time, they are not in a mood to get a prize, but they're in a mood to show that, hey, we are with you. Let us all talk together, learn together. That was the secret of this organization. Founder, Professor Karim, made the name Oncology Club, not a society, not a foundation, so that we can all talk and learn. So with these few words, by thanking everybody, I want to end the session by asking our president to formally close the session. Professor Haisa.
Okay. Thank you, Kamal. Very, very nice afternoon today. Very nice discussion about the management of breast cancer. Our junior faculty did a very good job, Dr. Nusrat and Tawhida. Hopefully in future, I shall want to see them as moderators. Very soon I shall have to see them as a moderator. So thank you all very much. And it's time to.
So goodbye. See you next week.